My name's Anthony Fogg. I'm an orthopaedic surgeon. I was appointed as a consultant to the Great Western Hospital in Swindon 24 years ago, primarily as a spinal surgeon. I also perform regular joint arthroplasty of hip, knee, arthroscopy procedures on the knee, and was at one time a general surgeon, but have now concentrated mainly in spinal surgery. Spinal surgery is quite a complex subject, as I'm sure you know. So what I tend to do is, like most surgeons, I see people in outpatients, assess their conditions by means of history-taking examination, specialist investigations, which are provided here for me in the way of MRI scans, X-rays, and various other specialist medical investigations, and try and choose those patients who may benefit from my particular expertise in spinal surgery, and for those who do not, refer them on to what I perceive to be the most appropriate alternative treatment management plan. There are a number of typical patients in spinal surgery. The typical patient I would see, who I know I can do something for, is the young patient who has suffered with sciatic pain in one or other legs for more than 3 months, which pain has been refractory to treatment by pills or physiotherapy or injections or osteopathy, and whom there is an obvious cause, such as a disc prolapse, which I can then surgically remove and relieve the patients of their sciatica. They normally are between the ages of 25 and 45. The vast majority of patients suffering with what we call mechanical back pain, attributable to a combination of early degenerative changes that take place in the lower lumbar discs, probably primarily as a consequence of a genetic predisposition to that. They subsequently go on to develop pain from either the disc or indeed from the subsequent arthritic changes in the joints at the back of the spine. They don't suffer with sciatica. They have mechanical, quite often intermittent back pain, which they are not completely disabled by, but it interferes with a considerable number of aspects of their life. Those patients would usually be assessed in much the same way as all the other patients, with MRI scans, quite often sent for physiotherapy in the first instance. Where the pain is so severe that physiotherapists are unable to break into the pain cycle, we often refer them for targeted injections into the back, either by ourselves or by our consultant radiology colleagues. Very occasionally they are referred on to manual practitioners such as osteopaths or chiropractors, although in my particular practice that treatment modality is usually provided by the physiotherapists. So physiotherapy and then an educational rehabilitation of the patient so that they manage their own pain rather than being reliant on other members of the fraternity to do it for them. In terms of coming to see me, most patients obviously are referred in by the general practitioner, the GP being the first port of call in the primary care sector for patients. They would tend to go and see their GP quite early on in the progression of their illness, particularly if they've got severe sciatic leg pains, which can be very disabling. The GPs, or the ones who have experience of this, will take note of the fact that we as surgeons will tell them that 95% or more of patients with sciatica, probably as a consequence of a disc prolapse, will actually recover spontaneously within a period of about 3 months, during which time they should be given appropriate analgesics, anti-inflammatory medications. They should, in the first instance, when the pain is severe, rest. Unlike back pain, it's the sciatica which resolves with rest. And then gradually over a period of time they can reintroduce themselves into society, work, etc. And by 3 months the vast majority have actually resolved or improved to a point where they no longer need any intervention. If the pain persists certainly beyond 8 or 10 weeks and it doesn't look like it's settling down, that's the period, that's the time at which we would advise GPs to send patients out. There's a slight difference in the private sector as opposed to the NHS sector, because the pressures in the private sector are nowhere near as high as they are in the NHS sector, and patients tend to get sent and seen sooner. Nonetheless, we do not treat people differently, we would still say there's a good chance, and we would try absolutely everything in order for them to avoid surgery, believe it or not, before actually sending them off for an operation. Well, let's take a typical case again. Let's take the younger person who's had a disc prolapse, who's suffered with severe sciatica, which has prevented them from working, has interfered with all aspects of their domestic and social life. They are frequently working, they're not able to work, and in some instances their job and therefore their livelihoods are being threatened. They have mortgages. So when you operate on them, when they come into hospital, they have a lot of tension and a lot of stresses, not just the pain which they suffer. And it is noticeable when you actually do operate on these people, most of whom will wake up the day after surgery in the morning with no pain in their leg. They are intensely relieved. A lot of them think they'll be able to get over the surgery very quickly, but it takes a lot longer because of the stress that's been involved, both physical and emotional stresses which they've suffered. So anything up to 6 weeks after the surgery is what it takes for people to get back to some form of realistic living.